Chapter 25 is going to be covering suicidal and non-suicidal self-injury. Basically, this is just definition of what suicidal ideations is and suicidal attempt. Suicidal, in general, it's an intentional act of killing oneself by any means. And then the ideation, they're thinking about hurting themselves, killing themselves. And then attempts is where they engage in activities they may kind of scrape or like slash their wrist or something minor injury, uh, or something maybe like overdose again. So this is what they attempt, a client may attempt. Non-suicidal. This is intentional to do damage to one's body tissue without conscious suicidal intent. Again, because they may do this because they are not socially active, interacting with in a relationship, or these are mostly clients that kind of keep to themselves, or maybe if someone like their values, beliefs, if they are sanctioned or they are stigmatized, so they have a tendency to have non-intentional. This is basically some epidemiology. Suicidal accounts for about 10% of deaths for all ages, and then about the second leading cause of death for 10 to 34-year-olds. And it kind of breaks it down. The older you get, this more the incidents are higher. Um, this is a case study. This is a 14-year-old identified as transgender, saying I've known since I was real little that I was meant to be a girl. I'm a girl on the inside and I always have been. As soon as I'm of age, I'm going to get surgery for a gender reassignment. Having been Um, I've been have been saying saving money for it as long as I can remember. In the meantime, I asked my friends to call me Gina instead of Gino. I grew up with these same kids, so my friends, it's really no big deal. With the friends, which um, he's saying it's no big deal with his friends. However, as you can go back and see, as we talked about cultural and how people are sanctioned based on their cultures or values, beliefs, and the fact that this 15-year-old, 14-year-old is transgender. So, however, as the case study goes on, um, Gina talks about growing up in small neighborhoods, going to school in the neighborhoods. Now she's in a larger school, so basically her friends beginning to push around on the hallway, so they began to bully her. And so recently, Gina dresses and grooms herself as a girl, tries to use the girls' bathroom, which was allowed at small private schools, but again, as she got in big public schools, it felt like it was disgusted. So again, as we go back looking at the epidemiology, then the suicidal itself, again, um, it's a bearing on an individual. So they go through different episodes of stress and they become depressed. Sometimes they die as a result of depression disorder, suicidal, substance abuse, and then they may be impacted with or diagnosed with psychosis. So again, these classes again they are risks for personality disorder, trauma-related disorders, anxiety, so um, again, it's based on some biological factors. It has been linked to both genes. Again, it also could be may be linked to low serotonin level. This is a neurotransmitter, as you remember. Again, family conflict, low parenting monitoring, clusters of suicide. Uh, Things like copycat. Teens are at a high risk due to immature prefrontal cortex. This is the brain. So again, going back to some of the factors, again, going back with has these children been traumatized? They're in a low parental monitoring environment. And then these are some culture factors here that these clients may be impacted with. Again, it may be against their religion or their family values. That they've again bullying. Um, these clients have a high incidence of suicidal, um, and there's no exception across the race or ethnic lines for the most part. Um, these are other some social factors. Again, health problem, financial problem, legal problem, loss of housing, relationship problem. These are all put these clients at risk for suicidal. Um, so again, when we assessing these clients, we want to look at all cues, verbal and nonverbal. Overt, those are overt, those are covert, those nonverbal cues. If they have a plan, how they plan to carry it out? Do they have a gun, or do they plan to overdose, or has there any been any attempts in the past to commit suicide? Is there a family history again? Sometimes these clients they go from sad to happy. They have a switch in their moods. Okay, then do they have social support system? That's another factor that we need to assess and look for. So you're worried about a close friend who recently broke up with a boyfriend. She's taken the breakup very hard and seemed depressed. What are some questions you would ask to assess for suicidal ideation? First of all, you want to know again what is, or do you have a plan? Have you been thinking about killing yourself? Um, what provoked this? So these are the questions. Who do you talk to? Do you have any support? So these will be some questions that you could some discussions you can have. Also, health professionals, again, we're doing a self-assessment. Again, we want to know, we need to acknowledge the feelings, avoid counter transference. A lot of times we feel, um, if y'all remember the term counter transference? Remember that. Sometimes we feel that if we are taking care of a client and we can express our feelings onto that client, so again, we have to be very conscientious of that. So we may feel fear, grief, anger, and puzzle, and then also. So just keep that in mind. These are also some risk factors here that may, I'm sorry, some diagnoses that may be applicable to these clients. They're not all inclusive. Again, it could be that they at risk. They may have self-care deficits where they just don't take care of themselves. They don't sleep. They have problem with their nutritional status. They become anxious. They may have anxiety. Then again, we want these clients at the end of the day suicidal, we want them to, our outcomes is to put some interventions in place, some goals in place where these clients will not attempt to hurt themselves. And how can we do that? Again, we want to look at some preventative efforts, getting these clients to to care, make sure they have the support that they need, listen to those clients. And let me just go back a minute when I talked about examples of verbal and nonverbal clues, we want to make sure that those things that are overt, they tell you, I can't take it anymore, or life isn't worth living anymore. I wish I was dead. These are all overt um, indications that put a client at risk for suicidal. And then covert, it's okay now. Soon everything will be fine. So they may tell you it's okay now. They're letting you know that it is okay. This is a covert statement. They're not coming directly to say that I don't want to live anymore, and I won't be a problem much longer. This is covert as well. They're kind of covering up. I'm not feeling good to me. Nothing feels good to me anymore, and probably never will. Okay, how can I get my body donated to medical science? These are all covert indications, and then the list can go on and on and on. So again, we need to make sure that we assess these kind. Like I said, we want to ask them as far as our intervention. Have you felt like this before? Can you tell me? Have you been thinking about death recently? They ask the question, do you feel suicidal? Okay. If so, what is your plan? We want to know what's the plan, if there is a plan. So again, um, so we can have a good dialogue with this client, our clients. Okay. So again, milieu therapy, we need to document. These clients may require one-on-one observation. If they come present and then they're going home discharged, they need someone that's going to be responsible for taking care of them that they need to be on a direct supervision. Just depending on how severe that they are. Okay. And again, as far as an environment, that environment needs to be safe. We need to make sure that the environment is safe. If a client is at risk for suicidal, again, we need to make sure what is the plan. If they will tell you that, we need to make sure we document and closely observe these clients. Also any knives need to be removed. Uh, Plastic utensils, we need to use those if possible. And then again, we have to watch them with the plastic utensils because they may swallow that. And then certain plastic utensils can be sharpened. So again, environmental safety guidelines are very important. With these clients need no private room. They need to keep the door open and no, all the time. Again, if they're inpatient, we need to there has have close observation. Bathroom needs to be secure. Locks, doors needs to non-patient areas so they can't go into another room and get equipments or things like that. Monitor and remove any potential harmful gifts. Again, if they're inpatient, if the family member or somebody brings something in to them, it has to be checked. We don't just let the family or a visitor bring gifts in because they could have something in there that will be harmful. In the presence of the patient, when you assess their belonging, you need to do it in their presence. Okay, you want to search them, and assess belonging and search patient for harmful objects in patient presence. You don't ever go into somebody's belongings without them being present because they could very well accuse us, the staff of taking something or stealing. So ensure that the client do not bring or leave harmful objects, okay? That the patient do not bring or leave harmful objects. We need to make sure if they have a food tray, again, make sure there's nothing left in the room that's going to be harmful to that client. These clients, they may benefit really well from um, brain stimulation therapy to decrease their ideation. They're also, just depending if they're depressed, they may be on some antidepressant medication again. So just depending on what the treatment modalities are, how how best, well, I'm sorry, it fits for that client. So again, like I said, documentation. You need to make sure we document. Close observation, close observation. Like I said, again, back to the pharmacology. Um, the antidepressants are useful for these patients. Again, to help with that, their depressive mood or the anxiety. Okay, close monitoring. I can't stress that enough. Even when we give them medication, we don't want to give them even at home. We have to. The family member needs to monitor the medication. Only give them, maybe a 3-day supply or three-dose supply. I'm sorry, because the more you give them, they're going to they may be at risk for overdosing. Okay. So like I said, if they are psychotic or bipolar, they be on an antipsychotic medication prescribed. So preferably, we need to make sure that because they definitely will benefit from those second generation medications because they have fewer adverse effects. And as I mentioned earlier, your brain stimulation therapy for those clients that are acutely suicidal. It also helps with depression and psychosis as well. Also, there's a medication called ketamine. It can be given IV or nasal. It's a rapid acting antidepressant, um, which also is used to reduce suicidal ideation. Um, Again, glucamate. It increases the amount of glucamate in the brain. Okay, it is. However, IV administration has not been approved by FDA, but your book mentions it. But like I said, the FDA recently approved the nasal spray, the ketamine, ketamine. Now, there's another medication that also may be used, clonazepam, 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 Colzapine. Now, there is an adverse effect. We have to closely monitor these clients with this medication, closely monitor them for the side effect, which include agranulocytosis, myocarditis, and altered glucose metabolism. Agranulocytosis, myocardia, myocarditis, I'm sorry, and then altered glucose metabolism. I repeat, clozapine. Okay. This client is hospitalized for suicidal ideation after 2 attempts. For the first 2 days of hospitalization, the client eats only 20% of meals and stay in the room between groups. By the fourth day, the nurse observed that the patient is more sociable, eating meals, and has a bright affect. So, with that being said, we're going to look at this question. We're going to determine which factors should the nurse consider in this case. Again, we talked about non-suicidal injury, the clinical picture again, looking at the epidemiology here of non-suicidal. Again, it's a type of injury for its intentional damage to one's own body tissue without consciously knowing about it, without a conscious intent. These clients have been, like I said, they've been sanctioned by the culture or society. And also, there are other comorbidities that these clients may exhibit with non-suicidal injury. Usually, these clients they may have things like major depressive disorder, anxiety, eating problems again, and also they may resort to um, substance abuse, drug and substance abuse. Um, as far as the biological factors, there are several neurotransmitters that seem to be linked to this disorder. Um, your MOAs, monoamines, I'm sorry, including serotonin, dopamine. Okay, these are all neurotransmitters that appears to be associated with non-suicidal self-injury. Um, as far as cognitive factors, again, these clients they have negative thoughts, they have negative perceptions. Again, for example, cutting may result in reduced anxiety. So if they feel if they cut themselves, it will help decrease the anxiety, perhaps. Okay. So then, environmental factors. Again, going back to parental maltreatment or neglect. You know, again, it could be related to again what the environment that they were in. Parents may have gone through a divorce. There may be some socioeconomic challenges in that environment. And then again, societal factors. Um, Housing could be example. As far as the nursing process, it's important that we assess and emphasize importance of empathy. Show empathy. Look for triggers, and then also self-assessment. Look for transference. Also, these clients, the diagnosis could be risk for self-mutilation. Also, it could be actual self-mutilation. So our outcomes, we want these clients to be able to cope. We want them to be actively and socially involved, get support groups for these clients. We want them to adhere to the treatment regimen. So there's a 6-step approach when we're planning care for these clients. Safety, we want to help these clients to develop self-esteem. There's a motive. Discover the motive in this role. There's a motive. Let them know that they're worth something. They can be productive. We want them to be able to be in control of their behavior, positive coping skills, and we want to get them in. Make sure they're get them in the maintenance phase on their medication, in group, to keep them from, and then eventually get them to the recovery phase. And we want to make sure they maintain. Now, it depending on whether or not the client you know, had some injuries to self or whatever, our priority would be caring for those injuries first. And then again, we want to make sure we protect the client. Um, uh, well, you're gonna, if there's a client presents with an injury, of course we're gonna take care of the injury first, and then we're gonna go ahead and do our mental assessment for suicidal ideas. We're not gonna assess first if somebody coming in with an obvious cut or an obvious overdose. We don't want to know what happened or why it happened at that moment. We want to go ahead and treat the injuries. Okay. Some of the pharmacological therapies again could be medicines such as your SSRIs, paroxetine, which is the same thing as Prozac. Your second generation medication, Ciprosol or Abilify. Okay, could be some examples of the medication that may be very effective for these clients. So the overall goal for these clients is going to be safety, get these clients into therapy, observation, close observation of these clients, assessing. We want them to refrain from obtaining any self-injury after when we go through the evaluation process. Okay. Again, we want them to be able to get assistance that they need. And these clients will need to be treated and evaluated on an ongoing basis. So again, as far as our psychological therapists, these clients will benefit from group therapy. Um, Also, once we get them to that phase when they really want to talk about it, cognitive behavior therapy also would be excellent therapy for these clients. So again, the most important thing, if they have a plan in place, we need to evaluate it. How important it is that they do not have access to their means, their plan that they have in place to commit suicide.